Good morning. I am so happy to be here, and I'm delighted to introduce some fascinating people. As you've just heard, the title of this panel is From Fear to Fierce, and you're going to find out in a second why these people are featured on this panel. They have some fascinating stories. To my immediate left is Devon Still, a former NFL defensive end who played for the Cincinnati Bengals and other teams. Then we have Richard Pazdur, who is director of the Oncology Center of Excellence at the Food and Drug Administration, or I just call him the FDA Cancer Czar. To his left is Bryce Olson. Bryce is the global strategist for Intel's Health and Life Sciences Group. He also has advanced prostate cancer. Finally, we have Stephanie McMahon, who is the chief brand officer of WWE, World Wrestling Entertainment. Thank you
For those
all.
of you who don't know.
For those of you who don't know that little company. Anyway, thank you so much. Each of you have had a unique experience that has changed your lives. What led you, Devon, here today? How did you get from fear to fierce?
Well, first of all, can I get a show of hands of how many parents are in this audience right now? Right, so I asked y'all to remember the moment, when your child was born and you held your child in your arms for the first time. And you was in amazement that you was able to create a human being that you love so much. And that first oath or that first promise you made to that child as she laid in your arms that you was gonna love her as much as you could, that you was gonna provide the best lifestyle that you could, and that you was gonna protect her as much as you could. See, I made that same oath and that same promise to my daughter on May 6, 2010. But that promise was broken on June 2nd, 2014, when my daughter was diagnosed with stage 4 neuroblastoma. And I couldn't protect her. I couldn't stop her from having to go through that cancer diagnosis, and it shook my world up. And I decided to use my platform as an NFL player to raise awareness for all families who are battling pediatric cancer.
Thank you. We'll hear more about that in a minute. Dr. Pazdur?
Well, I have both a professional and a personal story. My professional story is that I'm a medical oncologist. I began my training in 1979. I treated patients and was on the faculty at major universities, both in Chicago, Detroit, and I worked most recently in the 1990s at the University of Texas MD Anderson Cancer Center. And then for the past 19 years, I've been the head of oncology at the FDA. So that's my professional story, both from an administrative standpoint at the FDA, as well as taking care of patients before that. My personal story is that of a spouse whose wife passed away from ovarian cancer about 3 years ago after a battle of about 3 years. My wife was a nurse, an oncology nurse. In fact, I met her on my first day of fellowship when I started my professional journey with cancer. And having that unique insight of both of us being in a field is one that has its pluses and minuses. I always tell people, when my wife had the diagnosis of cancer and I received that, we underwent a story where we read the book before and experienced that book with others, but this became a much more personal story, but we had that complete story in front of us.
Bryce?
Hi, I'm Cancer Farris, and the reason why I can say that is because I learned how to understand what was fueling disease at a molecular level in the DNA, and that opened up the doors for me to basically find stuff that would be much more targeted and less toxic. But I didn't used to be this way. I was pretty fearful, honestly, at first. I went through the same one-size-fits-all, everybody gets the same, trial and error treatment paradigm that we have today. The cut, burn, poison, and in my case with metastatic prostate cancer, starve the cancer out of you. And it probably bought me some time. It increased the quantity of my life, but not necessarily the quality. So I started to lose hope. I didn't think I'd see my kid get out of elementary school, and I kind of came to terms with my own mortality. But fortunately for me, when I went back to work, I work for Intel Corporation, and they do a lot of work in the health and life sciences group, using technology to help those guys make new discoveries. And I pushed my way into that group, and once I learned, there's this new thing called genomics and precision medicine, and how you can understand what's fueling disease and open up new doors. And then I just said, well, sequence me. I want to do this for myself. And it changed the course of my life, really. So,
Stephanie.
Well, first of all, it's truly an honor to be here with all of these panelists and with all of you. Thank you so much for everything that you do to help put an end to cancer. My story is WWE, and my husband and I actually founded a fund called Connor's Cure, which now sits with the V Foundation, and it's in honor of an 8-year-old boy named Connor Mahalik, who was a WWE fan who unfortunately lost his fight. And I'll never forget the first day that I met him. He was backstage after a big event that we have called the Royal Rumble, and he was talking to some of our superstars. And you could tell he was sick from how he looked. He didn't have much hair on his head. He had a big scar up the back of his neck, a big swollen spot here on his head. And I went over to him because you would never know it from his personality. And he started telling me how he was wearing the T-shirt that Sheamus, who is one of our superstars and is 6'5", 300 pounds, looks just like Devon. Well, maybe a little different, same size. But the shirt was dragging on the ground, and he's so excited telling me all about the shirt Sheamus had given him and, you know, all of this incredible stuff. And I asked him if I could have a hug, and he said no. And I said, well, how come? And he said, because I give choke-out hugs, and I'm afraid I'm going to choke you out. And I was like, try me, buddy. So he gave me one of the greatest hugs that I've ever had. And in that moment when I was standing up is when his dad whispered in my ear that Connor didn't have very long to live and might not make it to the next event we had in Pittsburgh. And my husband and I were trying to just find a way to get him to live a little bit longer, to give him something to hang on to. And we invited him to WrestleMania, which is like our Super Bowl. And the doctors warned him that he'd never be able to make it. He wouldn't be able to survive the trip. Even if he did, he'd be so sick he wouldn't enjoy the event. And his family decided they were going to give him the experience that he wanted. Not only did he survive, but he thrived. He didn't need as much help getting dressed. He was able to feed himself. And his father said it was as if he had his little boy back. And Connor's favorite WWE superstar happened to win the whole event in front of 80,000 people at the Mercedes-Benz Superdome in New Orleans. And that superstar brought the WWE Championship right over to Connor in the front row. And I'm so grateful for that moment because it was about 3 weeks later that he died in his father's arms. And I just made a promise that we were going to do everything we could to find a cure so that no child or their family has to suffer the way that Connor did. And that's just one story. And Devon started the panel asking all of you, how many of you are parents? I mean, we are all here to find a cure for all of these cancers that are affecting all of us at every level. And it's going to take every single one of us to make it happen. So again, thank you.
Thank you. Dr. Pazdur, I'd like to start with you. So from a professional standpoint, you've talked a lot about how we're in a new era of oncology therapeutics. What do you mean by that, and how do you prevent patient expectations from getting ahead of where we are? And then from a personal standpoint, how did the loss of your wife affect how you do your job?
Well, a lot of questions there. First of all, I think having been in the field for almost 40 years now, I've seen many changes. And I think what we're witnessing, especially with the molecular targeted therapies and biological therapies, truly advances that are being underpinned by really advances in science. When I began my career in the late 1970s, early 1980s, basically we were trying to find a needle in a haystack, basically, with drugs. We did large trials without any knowledge of what activity a specific drug might have in a specific tumor. Now we have a much more sophisticated approach where we can actually select patients that have a higher probability of responding to a tumor, to a specific drug, rather. So I think the major thing that has happened is the fruition clinically of basic science advances that really occurred over many, many years here. And I think that is a rewarding thing to see from a professional point of view. From a personal point of view, I think my wife's experience really underscored, especially when you're dealing with a disease and seeing the toxicities, is how we underreport side effects of chemotherapy and what patients actually undergo. And that's one of the big initiatives that we have at the Center of Oncology Excellence, that we really want to incorporate the patient's viewpoint in evaluation of treatments as well as their disease course. So I think that was probably the major impetus that I could say as the impact that my wife's illness had on me professionally.
Bryce, staying on that theme, you have a radical message for patients. Why don't you tell us what it is, and is precision medicine really all that it's cracked up to be? There's a lot of controversy about it.
Yeah. Well, so is precision medicine today going to cure people? No. Is it going to extend your life potentially longer than the standard of care would? Yeah, I think so. And to give you just a practical example of what I did, maybe that's probably the easiest way to explain it. So I have metastatic prostate cancer. On the cell surface of my cancer cells are these androgen receptors, and they're trying to bind to testosterone. It's like eating, right? It's just eating stuff. And then it folds into a nucleus. And in my case, what genomic sequencing showed me was that I have a specific pathway that was screwed up. So the pathway was messed up, and the tumor suppressor gene that's supposed to be stopping cancer on that pathway was also messed up. To give you an analogy, to pay homage to the late, great Burt Reynolds and that amazing movie, Smokey and the Bandit, right? So it was like Bandit and Cletus are delivering beer from like Texas to Georgia or wherever, and that's the pathway that they're choosing. But Buford T. Justice and Jr. are like messing around on the highway, and they're not paying attention as Cletus and Bandit go, right? So that's what was going on in my situation. So once I found that out, that opened up new doors for me, because once I found out I had a hyperactive PI3K pathway, I went after a PI3K inhibitor. I just found a clinical trial. And the conversation was really funny. I call him up and I say, I want into your trial. I'm sorry, there's no space left. Yeah, but I got genomic sequencing data. You have what? I have genomic sequencing data. I know I'm a perfect molecular match to the drug you're trying to test. Wow, no one's ever called us with that before.
Come on down.
Can you come down? We'd like to evaluate you. And I was able to shut it down for 2 years doing that. So I'm a huge believer in this space. I love research projects like the Metastatic Prostate Cancer Project from the Broad Institute and places like that. We need to push more of this research and drive it.
Thanks. Stephanie, you weren't involved in pediatric cancer, were you, before
I was not.
Before you met Connor the Crusher? So what part of that has surprised you the most? What are the biggest good surprises and perhaps disappointments, bad surprises about the pediatric cancer effort?
Well, as my work continued to evolve, I'm actually now a Henry Crown Fellow at the Aspen Institute, and as a part of that fellowship, I'm launching a venture, and right now it's called the Pediatric Cancer Action Council, where we have a very bold goal, and this is not public, we haven't publicly launched yet, but we have a very bold goal of finding 4 new treatments in the next 5 years, because I think you need a bold goal to drive change. And the whole purpose of this is to bring together all of these different types of collaborative minds, because what surprised me the most, 4 drugs have been developed for pediatric cancer in the past 4 decades. 4. Yeah. 4% of government research money that goes to funding cancer in general goes to pediatrics. And it's unfortunately because of a business model, because there's lack of incentivization for pharma. Clinical trials are tough because it's kids and because the populations are so small. We need to break the models. We need to reimagine the models. We need to bring together all of these different silos and get people talking. There's so much great work being done, but there's a lot of repetitive work that's being done. And people just aren't having the option to really come together in these same spaces. There's a lot of conferences, a lot of conversation, but there's not a lot of action. There's a lot of barriers, and I think that was the biggest surprise to me. There's a ton of surprises to me, but there's a lot of opportunity in that. I don't want to be negative, I want to be positive. There's opportunity for change, and that's what this conference is all about.
Thank you. So Devon, you were in a very unique situation because so many people across the United States were watching your situation and your little daughter, Leah, deal and struggle with the cancer. Can you tell us what was that like? And Was there something about the people who you met along the way, maybe in hospitals and facilities, that made you most interested in the financial aspects of it and in helping people with non-medical bills like their mortgages and groceries and utilities?
Right. It was really overwhelming to see the amount of support that we got around the country come to the aid of my daughter. And what was most surprising about it is, you know, at a time where there's a lot trying to divide us in this world, I watched my 4-year-old daughter unite the country for a common cause and to fight childhood cancer. And I realized then that we needed to use this platform to really make a change in the world. And one of the reasons why I thought about starting the Still Strong Foundation, which financially assists families with household bills, was because when she was diagnosed, I had to make one of the hardest decisions I ever did in life, which was to leave her in Philly to receive treatment so that I could go back out to Cincinnati so that I had the insurance to pay for her $1 million treatment. And that sparked the idea of starting the foundation. But it was one time when I was in the hospital and I took Leah to the playroom because she liked to color to pass time. And when I walked in there, there was an 8-year-old girl sitting at a table with an IV pole next to her coloring. And in that IV pole, there was chemo dripping down into her Broviac catheter that hung from her chest cavity. So me and Leah decided to sit next to her and color with her. And after 5 minutes of sitting with her, she opened up and she let us know that she spent a lot of time in the hospital by herself because she came from a single-parent household and her mom had to leave to go to work to make sure they had a home to go home to when they weren't in the hospital. And it was in that moment that I knew I needed to start a foundation where we kept families in the hospital fighting together. And it's interesting because about a week ago, I was shooting a promo video for an event that we're having next month in Houston. And I partnered up with another foundation who does great work in cancer research. And, you know, she's working the promo. She has a lot of energy. She's smiling a lot. And then it was my turn to go. And I was the exact opposite. And when we reviewed the tape, she asked me how come I wasn't excited, how come I wasn't smiling more. And to be honest with you, I can't smile, I can't get excited when I talk about cancer because every time I go into these hospitals and meet these families and help these families, I get flashbacks of what my daughter had to go through, right? Because I'm a parent who suffers from survivor's remorse because out of all the families that I've met, all the families that we've helped, I only know 3 kids who went into remission. We're losing kids every day. You know, I can't smile because I know that there's somewhere in this country another 8-year-old girl or 8-year-old boy in a hospital fighting for their life by themselves. Or there's a little infant sitting in a crib inside their hospital bed receiving chemo by themselves because their parent has to leave to go to work. You know, I can't and I won't smile until one day that families don't have to experience the pain that me and 15,780 families experience every year when they hear that their child has cancer. Because I'm tired of watching kids die before they have a chance to live, and I really hope that everybody in this room is tired of the same thing.
Thank you. So I'm interested in your thoughts on clinical trials because obviously they've played a big part in all your stories. And I'm interested in, and yet there's a lot of talk and work on trying to get clinical trials to work better, to be more effective, to get results more quickly, to get more adults in them per the pediatric model. That's one area where the pediatric situation is ahead of the adult situation with a much higher percentage of children, patients in trials than adults. Dr. Pazdur, maybe you could start us on this. Where are we going on clinical trials? How do we make them better, and how do we make them easier for the patients? And also some of the issues that Devon brought up. These can be very expensive, even though the experimental drugs are paid for. by another entity, the people have other expenses.
There are several initiatives. One that the FDA and the American Society of Clinical Oncology and AACR and other professional groups have launched is really to look at eligibility criteria of trials and really to broaden the eligibility criteria so that patients that are entered on clinical trials will be very representative of the ultimate population that will ultimately receive the drug. At the end of the day, what we're really interested in is not what goes on in the clinical trials, but how that drug is going to be used in the real world. And therefore, it's important for us to really look at how clinical trials are done, and they have a specific purpose of really examining, does the drug work, and how does it work, and what's the efficacy of the drug, and also what the safety of the drug is. But ultimately, we have to have greater usage of the clinical trial to reflect, and greater enrollment on clinical trials to actually reflect the patients that will ultimately use the drug. In addition, we're very interested in seeing how the clinical trials could be adapted outside of the major cancer centers to where patients are actually receiving treatments. And I think this is a discussion that we'll be having with many of the professional groups and with many of the academic centers and researchers, really to take the clinical trials outside of the established universities and really put them into the community. So there's various ways of looking at a clinical trial. The other important issue is looking at real-world data. Now that we have electronic healthcare records, what does that mean? Okay, how do we use that data? As I stated before, what we're really interested in is how these drugs, from the FDA perspective, how these drugs are actually used in the real world. What are their side effects? What are their efficacy? Who benefits from these treatments?
Well, how do you find the patients who might benefit? I mean, if you have drug companies developing therapies for increasingly rare cancers, like Bryce's situation, if you have 1 million cancer diagnoses a year and you might have a drug that maybe could help 1,000 people, what do you do? How do you get from here to there?
That is a issue that needs to be resolved and really needs to be looked at. But here again, with whole genome sequencing, et cetera, that may give us more answers, more widespread availability of screening for genetic mutations, et cetera, rather than one drug, one mutation needs to be looked at. So this has to be looked at on a progressive level here of how we roll this out and how we look for these patients. Because ultimately, I think one of the challenges of all of these new therapies is really to determine who is going to respond to these therapies. And by selecting the patient with a specific biomarker, you will have a much higher probability of selecting the patient that will respond and therefore having a much more favorable risk-benefit for that patient and for the disease itself.
Bryce, you found that you responded twice, right?
Yeah, but I just have huge frustration with the fact that 96% of cancer patients stay on the standard of care and they don't move on to anything else. Only 4% of cancer patients actually go into clinical trials. Guess what? That's where all the new, cool things that actually might work are. How are we going to get more and more people into that? We need to really push that. We need to offload oncologists so they can have more support to enable patients to get into those kind of things. And then, like in my case, the only reason why I found my trial is because I had some genomic data, some unique data about myself telling me I was a good match. So we need to sequence a lot of cancer patients and then let entrepreneurs open up new Match.com type of capabilities, right? Where someone like me with my molecular driver can match into the right type of treatment plan and right trial. And oh, guess what? In this new world of molecular profiling, the patients are going to be all over the place. So to the point that was raised earlier, if one institution is running a trial, for a new drug that's going after a specific biomarker, specific mutation, they're not just going to be able to get patients from that community. They're going to have to get patients all over the place who are perfect matches. So we're going to need new ways to bring drugs to the patients and let patients, get into trials without actually physically going all the time.
Devin, your daughter, she was in 2 different clinical trials, plus she had a stem cell transplant. I mean, she really had a lot of different therapies. How did you navigate the system? How did you figure out, and what would you do to make things easier for parents trying to figure that out?
You know, it was tough. I was like 23 years old, so I wasn't ready to handle something of this magnitude, but you're never really, no matter what age you are, you're never really ready to handle this. You're just thrown into it. And I remember when she was diagnosed, the doctors gave us two options where we could do a standardized treatment or we can put her into a clinical trial. And I knew as scientists develop new treatments, the cancer is also developing, right? To find different ways to fight off the treatment. So I knew I didn't want to put her in a standardized treatment. So I decided to go with her first clinical trial, which was the MIBG trial, which is radiation that was designed to fight neuroblastoma. So we thought that that was going to, be the thing to save my daughter's life. But after 4 months of treatment, we found out that it didn't work, and the cancer spread all over her body. And a new clinical trial just got introduced called the CH1418, which is an antibody therapy. And that was tough to put her in. And I think that the biggest thing, like you asked, is education is vital in getting people to join these clinical trials because you don't know anything about it. And it's hard to do. Because with this new trial, we didn't really have a decision in it, right? If we decided we wanted to do the trial, we put her name into a computer, and the computer randomized, put her into a trial, whether it was arm A or arm B. And when you're fighting for your child's life and you don't have a say-so of what's going in her body, it's hard for any parent to make that decision. But because we made that decision, because we trusted these clinical trials and the advancement they were having in the cancer community, my daughter was in remission 2 months later after the cancer spread all over her body. So we owe it all to the work that the government and the scientists are doing to come out with new treatments.
Stephanie, what message would you like to leave today with the audience, either about what they can do to help or what you have learned in terms of the cancer experience that you've had?
I think it's to take action, to come together, to collaborate, to share our stories, to share our opportunities. I mean, what happens if we completely reinvent the standard of care? What happens if, as soon as you find out you have a tumor or someone that you love or your child has a tumor, they automatically sequence that tumor so they know exactly what needs to happen? Then they can get treated, whether it's through a different method of standardized care or it is through a clinical trial. Change the clinical trial models so that for kids, especially when there isn't a large population, even though a lot of kids are treated in clinical trials, there still aren't enough clinical trials for children. I also think there needs to be a rethinking in terms of pediatric cancer. Because the cancers are, in and of themselves, it is a rare disease because, by definition, the population is so small. What we need to do is actually, I think, and I'm not a researcher, I do not have a medical background, but I've heard enough that these cancers mutate in kids so quickly. And if we can actually find cures and treatments for kids' cancers, I think it will shed a huge light on adult cancers and how we can potentially treat them. So I would encourage everyone to think differently, to come together, to be open-minded, and to share, test. You need to be open to these new treatments, test these opportunities, and don't be afraid of change.
Dr. Pazdur, let me ask you, Vice President Biden and Dr. Biden have talked a lot about the importance of collaboration. Are you satisfied with the level of collaboration among researchers and even among drug companies? You've expressed a little bit of frustration about duplicative trials and efforts.
Yeah, I think we should never be satisfied. Okay, never. Okay, there's always room for improvement. And, we have many drugs being developed, and I do see duplicative trials. I do wish that pharmaceutical companies would collaborate more frequently, look at novel trial designs to work together on a pre-competitive environment, determining what patients may more likely respond to a therapy, especially with the targeted therapies and particularly with the biological therapy. So there's always room for improvement when it comes to collaboration, not only within the pharma space, but also within academics, within patient groups, within professional groups.
Bryce, I'm interested, considering your experience, of what advice you would give to someone with advanced cancer now. On the one hand, there is more hope than there probably has ever been. On the other hand, many of these people are not going to get the hope and the solution that they are seeking. So living with that level of uncertainty must be extremely difficult.
Yeah, I think so. And you know, I guess my main message to anybody out there who's dealing with advanced cancer and you're running out of options, just demand sequencing. Just go into your doctor's office and say, sequence me. Because that's going to open up the door to at least a better understanding of what's fueling your disease. You'll probably get a lot more engaged and empowered when you have unique data about you as an individual that can open up some new doors. And guess what? We need a lot more data. Mo data, mo better, right? The more data that we have out there, it's going to enable researchers to start finding the long tail on what's really driving disease. We can look at not just mutations, but what genes are being expressed, look at the tumor microenvironment and get deeper into that. Like, we seriously need a lot more data so we can make more research and develop drugs that are going to be more effective.
And if anyone wants to see how creative one can be about sending out the message, take a look at fighting advanced cancer through songs.
Yeah, facts, exactly.
Which is
using music to raise awareness for a new way to fight cancer. So
Bryce has, it's fascinating. Devon, I think you're going to have the last word. What would you like the people in this room and watching elsewhere to know and to do about the cancer challenges that we're facing?
One of the biggest regrets I had when my daughter was diagnosed with cancer was not fighting before she was diagnosed. Right? I was aware of cancer, childhood cancer, coming out of Penn State and participating in Thon, but I didn't know about childhood cancer. I didn't know until I was put into those shoes. And I feel like in order for us to beat this disease, it's going to take a team effort. It's going to take people coming together with all different backgrounds and knowledge to really have a chance to tackle cancer. So I would just urge everybody to fight now, even if you're not directly impacted by cancer, because hopefully one day we find a cure where cancer no longer exists so that you don't have to experience the pain that so many people experience every year when they hear the word that their loved one has cancer.
Thank you. Thank you so much, and thank you all for listening.
Thank you.